Welcome to this board review on managing psychosis, brought to you by Roadmap to Residency. Psychosis questions look intimidating, but they are built from a small set of repeating patterns, and once you learn to recognize them, the answers fall into place. Our goal today is not to reteach all of psychiatry. It is to show you exactly how these question stems are written and how to attack them, from a first episode of Psychosis to choosing an antipsychotic by its side effects, to maintenance therapy, to deciding who needs to be admitted. Keep your question bank and a trusted psychiatry review resource open alongside this video because these patterns stick best when you drill many practice questions. Let us get started. Here is what we are going to cover. First, how to recognize a first episode of Psychosis stem and choose the correct first step, which is very often a workup rather than a medication. Second, how to pick the right antipsychotic by paying attention to the side effect the question is quietly steering you toward. Third, how to handle schizophrenia maintenance, including when to reach for clozapine or a long-acting injectable. And fourth, how to decide who genuinely needs psychiatric admission. Along the way, we will walk through several practice questions together and explain exactly why each choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you attack the questions. Our first strategy applies to any first episode of psychosis. Before you commit to a psychiatric diagnosis, rule out medical and substance causes. Start with the timeline, because duration decides the diagnosis. Symptoms for less than 1 month suggest brief psychotic disorder. 1 to 6 months suggest schizophreniform disorder, and 6 months or more suggest schizophrenia. Note the age too, since a first break in a young adult is the classic stem. Then screen for substances and medical mimics. Look for stimulant or cannabis use, for delirium, and for abnormal vital signs or laboratory clues. In a genuine first episode, the tested next step is very often a urine drug screen and a basic workup, rather than immediately starting a medication. Let the timeline pick the diagnosis and let the workup come before the drug. Strategy 2 is choosing the antipsychotic by its side effects, because these questions rarely ask for the single best drug in a vacuum. Instead, the stem hides a detail that makes one agent right or wrong, so let that detail choose the drug for you. A young man worried about movement problems steers you toward a second-generation agent, which carries a lower risk of those effects. A patient with weight gain, diabetes, or a strong metabolic history steers you away from olanzapine and clozapine. Just as important, know the monitoring each drug demands, because the exam loves to test it. Clozapine requires regular white blood cell counts because of the risk of a granulocytosis. Many second-generation agents require tracking of weight, glucose, and lipids. When a stem describes a patient already on a drug, ask what routine monitoring that specific agent requires. Strategy 3 is recognizing the distractor traps that psychosis questions plant again and again. First, the movement side effect trap. The stem describes a movement problem and dares you to pick the wrong fix. A sudden muscle spasm early in treatment is acute dystonia and needs an anticholinergic. High fever with rigidity and confusion is neuroleptic malignant syndrome and needs the drug stopped and supportive care. Inner restlessness is akathisia. Read the exact picture before you answer. Second, the newly started medication trap. When a patient just started or switched agents, the new drug is often the culprit, and late-onset repetitive facial movements after long-term use suggest tardive dyskinesia. Third, the non-adherence trap. When a previously stable patient relapses, the stem is usually pointing at stopped medication rather than a failed drug, and a long-acting injectable is frequently the tested answer for repeated non-adherence. Let us work through our first practice question, which is built to test how you handle a first episode of psychosis. A 20-year-old man is brought in by his family for 2 weeks of hearing voices and believing his neighbors are spying on him. He has become withdrawn and stopped attending classes, and he takes no medications. On examination, he is agitated, his pupils appear dilated, and his heart rate and blood pressure are mildly elevated. The question asks for the most appropriate next step. Pay attention to his age, to how short the timeline is, and especially to those dilated pupils and elevated vital signs. Read the 4 options carefully and pick your answer, and we will reason through them together on the next slide. Let us break this down. First, spot the pattern. We have a young adult with brand new psychotic symptoms, dilated pupils, and elevated heart rate and blood pressure. Those autonomic clues were placed in the stem on purpose, and they point toward a substance-induced or medical cause hiding behind the psychiatric picture. Second, apply the rule. In any first episode, you must rule out medical and substance causes before committing to a diagnosis or starting a long-term medication, so the correct next step is to obtain a urine drug screen and basic laboratory workup. That is choice B. Third, eliminate the wrong answers. Starting a long-acting injectable or an oral antipsychotic jumps to treatment before you know the cause. Diagnosing schizophrenia is impossible when symptoms have lasted only 2 weeks and nothing has been excluded. Each distractor skips the workup the stem is begging for. The correct answer is choice B, the urine drug screen and basic workup. Here is our second practice question, and it is all about matching an antipsychotic side effect to the right treatment. A 25-year-old man with schizophrenia was started on a high-potency first-generation antipsychotic just 3 days ago. He is brought in with a sudden, sustained contraction of his neck muscles, pulling his head to one side, and his eyes are deviated upward. He is frightened but alert, his temperature is normal, and he has no rigidity elsewhere. The question asks for the most appropriate next step. The key details are the very recent start of a high-potency agent, the sudden sustained muscle spasm, and the normal temperature with no widespread rigidity. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, match the picture to the syndrome. We have a sudden, sustained muscle spasm within days of starting a high-potency first-generation agent, with a normal temperature and no widespread rigidity. That specific combination is acute dystonia, an early movement side effect, and it is deliberately written to be confused with the far more dangerous neuroleptic malignant syndrome. Now, why does the anticholinergic win? Acute dystonia is treated with an anticholinergic such as benztropine or diphenhydramine, so choice B is correct. Stopping the drug and cooling the patient describes treatment for neuroleptic malignant syndrome, which requires the high fever and rigidity that are absent here. A beta blocker treats akathisia, which is restlessness, not a spasm. Switching to clozapine is unrelated to this acute problem. The correct answer is choice B, the anticholinergic. Let us talk about schizophrenia maintenance because the exam tests it in predictable ways. First, continue treatment well beyond recovery. After a first episode, medication is continued for a year or more even once symptoms have resolved, and after repeated episodes, treatment is often indefinite. So when a STEM describes a stable, recovered patient and asks about stopping the drug, the tested answer is usually to keep going, and premature discontinuation is a classic wrong choice. Second, reach for clozapine and injectables at the right time. When a patient has failed 2 adequate antipsychotic trials, clozapine is the answer for treatment-resistant illness, and it comes with the requirement for regular white blood cell monitoring. When a patient keeps relapsing specifically because they stop taking their pills, a long-acting injectable is the answer for non-adherence. Match the reason for failure to the correct next agent, and these questions become straightforward. Here is our third practice question, and it is about deciding when a patient needs to be admitted. A 30-year-old woman with schizophrenia is brought to the emergency department by her sister. Over the past week, she has stopped eating and drinking because she believes her food is poisoned, and today she told her sister that voices are commanding her to end her life. She has a specific plan and no insight into her illness, and her vital signs are stable. The question asks for the most appropriate next step. As you read, count the danger signs. Command hallucinations urging self-harm, a specific plan, no insight, and an inability to meet her basic needs. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, find the danger in the STEM because the question stacks up warning signs on purpose. She has command hallucinations telling her to end her life, a specific plan, no insight into her illness, and she has stopped eating and drinking. Danger to self, together with an inability to care for her basic needs, are core criteria for psychiatric admission, and this patient is simply not safe as an outpatient. So the correct answer is choice A, admit to an inpatient psychiatric unit. Now the key distinction between the wrong choices. Adjusting her medication with a 1-week follow-up, referring her to an outpatient therapist, and discharging her home with her sister all leave an actively suicidal patient with a plan in an unsafe setting. On the exam, an outpatient plan is always wrong when the STEM describes imminent danger or an inability to meet basic needs. The correct answer is choice A, admit to an inpatient psychiatric unit. Here is a critical exam day pearl that lets you answer almost any admit or discharge question quickly. Work through it in 2 steps. Ask first, is anyone in danger? Scan the STEM for danger to self or others, meaning active suicidal or homicidal thoughts with intent or a plan, or command hallucinations urging harm. If those words are present, they push you straight toward admission, and an outpatient answer is almost always the trap. Then ask, can the patient care for themselves? If there is no clear danger, decide whether the patient can meet basic needs and stay safe. Someone too disorganized to eat, drink, or stay safe, or with no insight and no support, may still need admission. A calmer, well-supported patient with a workable follow-up plan can usually go home. Let safety, not symptom severity alone, make the decision, and these disposition questions become fast and reliable. That wraps up our review of managing psychosis for the boards. Remember the core patterns we covered. In a first episode, rule out medical and substance causes before you label the diagnosis or start a drug, and let the timeline separate brief psychotic disorder from schizophreniform disorder from schizophrenia. Choose the antipsychotic by the side effect the STEM is steering you toward, and know the monitoring each agent demands, especially the white blood cell counts for clozapine. For maintenance, keep treatment going well beyond recovery, reach for clozapine after 2 failed trials, and use a long-acting injectable for repeated non-adherence. And for admission, ask first whether anyone is in danger and then whether the patient can care for themselves. The best way to lock all of this in is to drill psychosis questions in your question bank under timed conditions and read every explanation. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.